Is it on? Okay, great. So I want to talk a little bit about some work that really has been going on, started over 20 years ago, and it's now at a point where I think it's really great that Margolis is around and ready to kind of take this going forward. So 20 years ago, the first panel on cost effectiveness in health and medicine, the field was really in its infancy, and there was a need for recommendations and for making decisions about how to do cost effectiveness and really what should be involved in those frameworks. So there was a book that was put together with a panel that was funded by the Health and Human Services in 1996, and that really then has been the standard for the last 20 years. About 3 years ago, a second panel was formed, which I co-chair with Peter Newman up at Tufts, and this was really looking to see, what has happened over the last 20 years. As all you know, there's been a lot of changes in the political environment. There's been a lot of developments on how cost effectiveness is used within the U.S. or not used within the U.S., how it's used in the international community, and a lot that we can learn. And there's also been a lot of things that through the first panel where there needed to be new research, there needed to be look into the application of the tools and see what we should do next. So we've recently completed this work, and it's going to be coming out in the fall. We're doing a large rollout at the National Academy of Sciences in December, and the recommendations we now need to be figuring out. Well, what are we going to be doing for the next 20 years? And that's really where I think Margolis could help make a dent in the research that we've identified as needing further development. One of the main things that we're changing going forward is that we're emphasizing to look at the different interventions, not only from the healthcare sector perspective, but also from a truly societal perspective, and have really done a lot of work at what that means when you want to be looking at a societal perspective. We often talk about looking at things from a societal perspective, but are very unclear what that entails. And so here's an example, and it's purposely hard for you to read because it's not supposed to be released yet until it's been published, but we're looking, we really designate within the formal healthcare sector what are all the different attributes that you want to look at in terms of impacts on the patients, on the caregivers within the formal healthcare sector, but then also how are the different interventions that we're doing, how is that impacting things within like the society, the social services, the legal justice sector, education, housing, really trying to see how are we impacting society as a whole. And so I think we're going to be putting a fair amount additional burden on analysts to be performing these cost-effectiveness analyses, but we're really hoping that they're going to be much more informative to stakeholders and the actual decision makers. Next slide. But through this process, we've identified a lot of areas where we need more research, where we just don't yet know how to do things or how to actually apply the work that we've been developing. And so here I've listed some of the future research needs where I'm really hoping that Margolis will help push these forwards. So we'll be looking at the use of multi-criterion decision analysis and group decision making, how to actually really use these as part of the decision making tool. Looking at valuing non-health outcomes. So this is obviously, especially when we're pushing people to look at these these sectors outside of healthcare, how do we actually value productivity? How do we value impacting social justice and education? Look at, obviously, the impact of decision-making behavior on cost-effective analysis. We actually, in this new version, we've included a whole new chapter on the ethics of cost-effectiveness analysis and equity considerations, and a lot of here are really just a very entry point in terms of going into that. So I think there's a lot of work that could be done there. Needing to do some work on operationalizing value-based pricing. There's a lot of work on what is an appropriate cost-effectiveness threshold and how to actually do some empiric work to figure that out. And so we have some of the leaders in the field that I think that we could be trying to bring together. The link between cost-effectiveness analysis and incentives for innovation, and then really how to have a role for cost-effectiveness analysis within health plans and guideline development. And it varies amongst the different guideline organizations in terms of whether they look at costs, whether they do that in a formal way, and really what sort of frameworks they use. And so we're really trying to, I think, bring some formal and robust methods to that part of the discussion. And so I'm now going to turn it over to Emily, who's going to talk about some other.
Thank you, Jillian, and thanks for having me here. I'm really excited to tell you about a project that we've begun working on recently. Just to give you a little background about the project, I came to Duke by way of FDA, and so I've always had an interest in the regulatory aspects of medical devices, especially today is actually my first day as a cardiac electrophysiology fellow, so particularly interested in implantable devices. This began, I was spending a day in the cardiac device clinic, and a major manufacturer called the faculty member staffing the clinic that day to tell her that there had been a recall of a relatively old pacemaker, and she got a list of 10 names that we needed to track down. There was no way to actually do that. You couldn't query the health records to find these patients. So we spent a day and a half Googling patients to find obituaries or other evidence of where they might be, because we had no way of finding them through Epic. So that was really unsettling, and that was the genesis for this project. We decided to do something about it. So we've developed what we're calling the Comprehensive Cardiac Device Safety System, which really aligns quite well with some of the work that is being done by folks involved with the Margolis Center and elsewhere to come up with a nationally integrated device surveillance system. But this, I think, project really illustrates what it means at the ground level, what the nitty-gritty is to actually accomplish that. And so we're starting small with just electrophysiology, just implantable devices in that specialty, and just at Duke. Here is some of the nitty-gritty involved in actually accomplishing that. We need to develop this database, which doesn't currently exist, which involves standardizing existing data structures. We'll be using unique device identifier structure to inform the way that we do that. We'll need to clean and import just gobs of legacy data that are messy, and then develop ways to manage the data moving forward, including ways to execute recalls. We need to be able to contact patients and let them know, or have a discussion about how to manage their recalled devices when that occurs, which happens with increasing frequency. And then to complement that, we're going to be developing some patient education and communication tools to help patients understand what a recall really means, what it means to have this device implanted. It's pretty clear that patients don't currently understand that, so that's a part of this project as well. And I mentioned that this was a small area. Implants from electrophysiology are dwarfed by other areas of medicine like radiology and orthopedics, ophthalmology. So we definitely are aware that there's scalability here to outside of electrophysiology, outside of cardiology, outside of the Duke Health System. And so we're building the system with an eye on that. And then obviously implications for device surveillance or investigation of safety and effectiveness are not lost on us. We're really focused on the point of care, improving our ability to manage patients who are in front of us, but we recognize that there are these clear implications for surveillance and investigation, so building a system that recognizes that as well is a priority. Next slide. And so while there's been a lot of talk about the future, which is really exciting to me in this area, the existing way this works is data goes from a patient's device to a provider and end of story. But I envision a future where, this is where information flows in all directions with patients at the center. We can incorporate safety data from the FDA and incorporate information from providers and from health systems and from manufacturers, and we can improve patient outcomes. So I look forward to working with all of you. Thank you.
Thank you. And thanks very much, Emily. And next up is David, who's going to talk about some of the regulatory policy changes that also reinforce this shift towards higher value in biomedical innovation.
Yes, thank you, Mark. So this is work with Mark McClellan and also Andrea Toomey, who's way over there as far away as possible. Hi, Andrea. And so this is on the Margolis Center side, and then on the Duke Global Health side, we have Mike Merson, Gavin Yami, and Cynthia Benet. This project is possible because of the Margolis Center. This doesn't happen without the Margolis Center, doesn't succeed without the Margolis Center. I'll tell you 3 reasons why. So first of all, the funder, the Global Health Technology Coalition, was interested in a university that had expertise in global health, which Duke has had now for several years, but also in Washington health policy. And who better now, because of the Margolis Center, than Duke? So that's the first reason. The second reason this is successful is that part of this project involves interviews. I say it is successful, I should say it will be successful. So the first interview is still a couple weeks away. But our survey design is so much better because we were able to draw on Peter Ubel's team, Kelly and Christine, who are here, helping us to make those survey questions so much better, those interview questions better. And the third reason is we wanted to be interviewing top people in this space. Who better to open doors for us than Mark McClellan and Mike Merson? So we have tremendous potential here. This happens because of the Margolis Center. So thank you, Bob. And by the time we all get together again in January, we should be finished. The report is due in December. So first interviews are in a few weeks, and then we should have a report in December. And then we're on to the next project. So we have so much we can do together in this biomedical innovation space, and I thank you for that.
Thanks. All right, David, thanks very much. So we've talked about healthcare reform. We've talked about biomedical innovation and putting them together to get more value for patients, improve health, to use resources more widely and efficiently locally in the U.S. and around the world. Next, we're going to talk about another major stream of activity that's very apparent in all of our discussions with the Duke faculty, is that there's some tremendous opportunities around education. This is a university with global reach, with sort of unparalleled respect and ability to deliver effective educational programs, and is already doing a lot relevant to health policy, and you're going to hear about how we're going to be working together to step that up. Barack?